Good day, everyone, and welcome. I'm Jack Van Horn from the University of Virginia, and I'm very proud to welcome you to this edition of our 2022-2023 Foundations of Biomedical Data Science Seminar Series. This lecture series is supported by UVA's Integrated Translational Health Institute of Virginia, the UVA Brain Institute, the College of Arts and Sciences, the School of Data Science, and through grants from the National Institutes of General Medical Sciences. Since 2016, the Foundations of Biomedical Data Science Seminar Series has focused on the use of data science methodologies, artificial intelligence, deep learning, and statistical modeling as they pertain to different themes in the biomedical and health sciences. This year's chosen theme is data science and the public health consequences of the COVID-19 pandemic, where each Friday we enjoy presentations from leading thinkers about the issues, the promise, opportunities, and the hurdles associated with understanding the secondary health effects of COVID-19. These include, but are not limited to, delayed health checkups and treatments, mental health-related concerns, drug abuse, increased obesity, and the long lingering health effects associated with the SARS-CoV-19 virus. Indeed, our 2022-2023 application cycle is now open, and we encourage junior faculty members working in areas such as infectious diseases, epidemiology, clinical medicine, population health, as well as in data science, machine learning, AI, statistics, and other relevant domains to consider applying. We believe this is an exciting and engaging program where characterizing the secondary effects of COVID-19 necessitates a unique quantitative and collaborative approach to understanding the data associated with this very challenging pandemic we've all are now emerging from. Participants selected for our Biomedical Data Science Innovation Lab program will leverage the presentations like the one you're going to hear today as vital material for a culminating in-person grant project development workshop to be held at the Lodge at St. Edwards Park in beautiful Seattle, Washington in June of 2023. Today, I am delighted to welcome our speaker, Dr. Adam Atherly from Virginia Commonwealth University. Dr. Atherly is an experienced health services research and health economist whose research spans numerous methodological and topical areas, including choice modeling, healthcare spending and expenditure modeling, evaluation of efforts to improve quality of patient care and safety, cost effectiveness analysis, amongst many other things. His research often focuses on consumer decision-making regarding health insurance plan choice, and more recently, value-based healthcare. Dr. Atherly has published more than 100 peer-reviewed research articles and book chapters, many focusing on the healthcare spending. He's also an accomplished educator who has taught courses ranging from introductory undergraduate courses all the way through to doctoral seminars. So in continuing our 2022-2023 Biomedical Data Science Seminar Series theme, Dr. Atherly's lecture today is entitled The Costs and Benefits of Different COVID-19 Interventions. And Adam's going to be describing for us that during the 2020-2021 time period, the United States employed a multifaceted approach to controlling the SARS-CoV-2 virus and to attempt to reduce mortality and morbidity. This includes non-medical interventions, aggressive vaccine deployment, and research into more effective approaches to medically treat COVID-19. Adam's going to discuss the incremental cost effectiveness ratio for three major COVID-19 policies, those non-medical interventions, the vaccine development and deployment, and therapeutics and care improvements within the hospital setting. As always, we are streaming this lecture live and full recording via YouTube. And if you are watching on YouTube, thank you so very much for joining us. Also, our specially selected 2022-2023 Biomedical Data Science Innovation Lab participants and alumni are very strongly encouraged to submit any questions they have in the chat feature of their Zoom sessions. I will synthesize these questions and ask them on your behalf during the last 10 minutes or so of the lecture. And with that, welcome, Adam. We're super excited to hear from you. Thank you so much for giving us a presentation today.
Thank you, Jack, so much for the introduction. I very much appreciate it. And I appreciate the invitation to the group. I looked through some of the prior lectures, and you guys are doing some really, really interesting work around COVID-19. So as Jack said, so I'm Adam Atherly. I'm at Virginia Commonwealth University, and this is work that I did collaboratively with Lena van den Broek-Altenburg, who's my former colleague at the University of Vermont. And the basic research question that we're asking, as Jack described, was what's the cost per quality adjusted life year gained of three different COVID-19 policies, non-medical interventions, vaccines, and hospital and health system innovation. And we really focus on that for the first 24 months of the pandemic. And just essentially, we're trying to figure out what the cost per quality gain was for the different public policies that were put in place. And where this came from is, so when COVID first came and we all got sent home in, I guess that was spring of 2020. It's always hard to know with COVID times. Alina Vandenbroek Altenberg and I were having, various Zoom conversations. And I think like everyone, we're at the 3 weeks to bend the curve kind of time. And, there are all of these really unprecedented policies being put in place to try to increase health for the population. And we just wanted to ask the question of what is the cost and benefits? By the way, are the slides showing up correctly, Jack and Gina?
Yes, they are.
Okay, good. So we just tried to ask the question of, how much is this going to cost, and what are the benefits likely to be of different policy alternatives? And one of the interesting things to us as health economists was that, especially in the early years, in terms of March of 2020 and in April and May, there was very little public discussion of the costs and comparing the cost to benefits. And we just had this idea of we're gonna flatten the curve and we're gonna protect the healthcare system, but the sort of cost question never came into the discussion, and at least that we could find. And so we then started to try to think about that question and just really do some back of the envelope calculations of, well, what is it likely to look like? And the initial work that we did was published. So I emailed Austin Fracht, who's the editor of the Incidental Economist, which is one of the blogs that the New York Times writes. We said, hey, can we write up a little piece for this? And he said yes. And so we just tried to do some really crude back of the envelope calculations in terms of what are the costs and the benefits. And there were sort of three big public numbers out there. That there's the infamous Imperial College estimate that said that in the United States, if we did nothing, there were 3.1 million people would die. The CDC also had a model, and their range was 200,000 to 1.7 million deaths, which I always sort of translate in my head of, we don't know. It doesn't seem good, but we really have no idea of the range of it. And then the World Health Organization estimated that there was 2.2 million deaths. And so what we did then is we just took some of the early estimates in terms of the costs. And really, we were working initially with the stimulus packages that the Trump administration was putting together in spring of 2020, and we were sort of, the stimulus packages in particular, there's no economic cost to those. Those are just transfers. But as a reasonable proxy for the public spending, we tried to calculate it out. And, what we came up with those just back of the envelope calculations is that in terms of the usual standard for what's acceptable for a cost per quality adjusted life year gain, which, and again, the United Kingdom, their standard is 30,000 pounds or about $42,000. In the US, we often use $100,000 as a benchmark. The only way you could get a number in that sort of $100,000 per quality range is if the number of deaths was at the high end of the potential range and the costs were at the low end of the potential range. And so just as we looked at that, we didn't seem, we sort of almost asked more questions. And then we went back a few months later and tried to, when we had a little bit better deaths. And, again, we especially on the early back of the envelope stuff, we really didn't have very good data at all. So for example, when you think about the quality loss, well, we did have ages from Italy and some of the early data in terms of the age of the average person who died. We didn't have any kind of quality numbers, so we proxied that using people with multiple chronic illnesses. And so our guess was that there was something like 7.8 qualities per death. We got better estimates later on. That looked like that was a little bit high, but when we went back through it again, we essentially, as we got better data, we started to get a range of somewhere between $500,000 and $6.7 million per quality gain. So, pretty far outside the usual range in terms of what was cost effectiveness. Because again, part of it was that the quality estimates were better. So we had a better number there, so we're a little high on our first estimate. And then the costs, of course, ended up being dramatically higher than what we first estimated. Kind of surprisingly, there's really not a whole lot in the peer review literature sort of asking these questions, and especially early on. And I'll say as a side, and I'll come back to this at the end of the talk. In health economics, we talk about the cost per life year gained all the time. I mean, this is sort of bread and butter stuff that we do, and so it's very odd that in this situation the sort of costs end up being completely ignored. In the peer review literature, then, here's a little bit of a stylized review. Miles et al. Sort of did an early estimate, and their estimate was sort of 230,000 to 3.7 million pounds, is kind of in the same range we were looking at. And they had sort of had the same question we did, where if the UK, they'll usually pay for a quality if it costs less than 30,000 pounds per quality gained. And now you've got something that's an order of magnitude higher, which is sort of an interesting issue. Schoenberger et al., they looked at, they essentially took that standard cost effectiveness number, and they said, given how much this is costing, how many lives do we have to save in order to justify it? And their number was something like 150,000 lives per month would need to be justified. And again, Yakashiva et al., and I'm part of et al. In that, we did some comparisons in terms of life gained versus life lost using the economic downturn to try to calculate the number of lives that would likely be lost due to the decrease in societal wealth. And just using that very crude measure, this the idea was you probably gained some lives here, but we didn't really do a cost number. And then I thought Bianchi et al. In an NBER working paper, I think did a better job than we did, and they took data from the Great Recession, and they tried to look at how many additional deaths came from the Great Recession, and their number was something like 800,000 additional deaths over the next 15 years, which they then applied to the COVID number, which suggests that there is going to be an extremely high number of deaths for all kinds of reasons that are related to the economic downturn that need to be balanced against the lives that you're saving through the lockdowns. So as we approach this, the way we conceptualized the cost effectiveness to COVID-19 interventions is that, we took the different things that were being done with public policies and put them into three big buckets. And I'll go through each of the buckets one at a time. The first thing you can do, so if you're going to reduce the number of people who die of COVID, there's essentially three things you can do. First of all, you can reduce the number of people who get COVID. So just keep people from getting sick from the beginning. So we do social distancing, masking, lockdown, school closures, all those kinds of good things. So keep people apart. That way they won't infect each other, and we can reduce the total number of people who get sick. The second thing you can do is you can reduce the number of people who are susceptible to COVID-19. And really that's code word for vaccines. So you can give people vaccines, so then as a result, they're less likely to die of COVID-19. And again, the vaccines perhaps didn't work quite as intended, as has been fairly widely discussed. But as far as our model works, as I'll talk about as we go through here, vaccines work just fine. And then the third thing you can do is if someone does get COVID-19, you can try to keep it so that they don't die of COVID-19. So you can try to do care innovations to reduce the number of deaths. And those are the really, if you think about it from a big policy perspective, keep people from getting sick, keep people from being vulnerable to being sick, or if they do get sick, keep them from dying. So those are the three big buckets. So in terms of non-medical innovations, obviously this is trying to limit people's physical contact and to reduce the probability of transmitting per individual. And it's just, hard. It's as during the height of COVID, 90% of the population was told to stay at home unless they were engaged in essential activities. And, just there's sort of an unlimited number of charts that you could show with this, but this, here's a couple that I like in terms of looking at the effect of the unemployment rate, where we went from essentially the lowest peacetime unemployment rate since we've been recording statistics on unemployment to the highest unemployment rate since the Great Depression in about a month as a result of a conscious policy choice. And, you can sort of see all of these sharp drops where it was just all of a sudden, lots of people didn't have their jobs. And obviously that has all kinds of costs, and particularly the value of the productivity lost when people were staying home. The second thing that policy is this vaccine development. The Trump administration put in place Operation Warp Speed, where they wanted to develop a vaccine for COVID-19 within 1 year. And I think to everybody's great surprise, the goal was to have 300 million doses to produce 300 million doses for COVID, with initial doses available by January of 2021. They supported 6 different vaccine companies to develop vaccines. 3 vaccines were developed and approved in under 1 year. All of them coming in, or 2 of them coming in December of 2020, and the second in February of 2021. So just remarkably fast development and deployment of vaccines, really very unprecedented. And then the third thing is medical and hospital innovations. When COVID first came, hospitals really didn't have much. They really had no game plan in terms of how to treat people with COVID. And so what the healthcare system did then is they very quickly repurposed existing treatments, and they did all kinds of things. A lot of these were treatments that were already available, and then there was some process of testing them on COVID-19. They also did a lot of changes just in clinical care, doing nasal oxygen and just moving people's physical body position on the hospital. A lot of the changes, especially the changes in clinical care, there's not really an economic cost associated with that. And putting somebody in a different position in their hospital bed is not an activity that really has a dollar sign attached to it, but it made quite a difference in terms of the probability of survival if you get COVID. So then as we looked at this question, then we just put this in a very standard cost effectiveness framework, where we wanted to look at these 3 policy options. We wanted to calculate the costs and the benefits of each of the 3 as individually, and then calculate the incremental cost effectiveness ratio to calculate a cost per QALY gained. Now, one of the big challenges with this, and actually one of the places we got pushback on in terms of the second incidental economist article we get, is what's the counterfactual? So so we know what happened. What is a reasonable alternative world that we could think about? And there's a couple of pieces to that. Is, for example, one of the internal group debates that we had quite a bit of is, was do nothing a reasonable, realistic alternative scenario? So what if the government had not said shut down restaurants, had not closed schools, had not told non-essential workers to stay home? Would people have still gone to restaurants? Would people still have gone to bars? Would people still have gone to baseball games? That's somewhat unknowable. And we could look at, for example, the last pandemic was in 1967, where nothing was shut down and people did sort of act as normal. Well, but that's pre-internet. Does that really apply to today? There's a couple of countries that didn't aggressively lock down, Sweden being the most famous, but Sweden is very integrated with countries that did lock down. So you can't really use that as a good counterfactual. Maybe Taiwan and South Korea would be our best examples of relatively isolated countries. Well, New Zealand as well, but it's a very short list when you sort of think about what would have happened if the government hadn't done it. So how would people react? And I'll come back to that point as well. And then in terms of how we did this for the cost, we did a review of the peer review and gray literatures, and we tried to make a good estimate of what the costs of the different policies were. And as the benefits, we did a susceptible, infected, recovered, or an SIR model. So in terms of costs, going through the three different policy options, start with non-medical interventions. The big cost is the reduced GDP as a result of the shutdowns. So the way that we calculated that number is that the Congressional Budget Office does economic projections. And so they actually put out a new economic projection for the next 2 years, 5 years, 10 years in January of 2020, right before the pandemic. And so they had full 2020, 2021 and beyond projections in terms of what they thought the economy would look like. They then obviously had to revise that as they move forward. So what we did in terms of the GDP loss is we have the estimate from 2020 pre-COVID, and then we have the actual numbers of what happened, and then we essentially just compared those two. Now, back to that question of what's the counterfactual. So if the government had said, you know, you can go to a baseball game and you can go to a bar and you can go to a restaurant, that's all good. Would people really have gone? And as I say, we tried very hard to find some place in the world that had not done anything that we could use to try to model what the behavioral reaction would have been in the absence of government intervention. And I don't find anything. So we assume, in the end, we assumed a 30% impact. We assumed that you would have seen a 30% reduction regardless of what the government did. That's really based kind of on Taiwan and South Korea, but it's not a very solid number in my view. I also don't think it particularly matters. In terms of healthcare spending, one of the pieces of this is that how much you spend on healthcare for COVID will be a function of how many people get COVID. So if you keep people from getting COVID through non-medical interventions, you're going to reduce some services. The other place that healthcare spending is affected is when you did the lockdown of the healthcare system, there was big reductions in delivered services. And so some care was deferred. So people who were seeking care never got it. Either they died or they recovered. Other people delayed care. So instead of getting my cancer treatment in February of 2020, I got my cancer treatment in February of 2021. So you have that delayed care. And then we have average cost numbers for hospitalizations by age groups. Lots of other costs. One of the effects of lockdown, obviously, is substance abuse went up quite a bit. So we have an estimate from the literature that it went up by 12%. Domestic violence went up dramatically. So the estimate is 20%. We also looked at increases in childcare for parents. So if you have people stay home and try to work from home, their kids something has to be done with their kids. And so we have that number in here. School closures are the second big piece of this. So there's a couple of different pieces here. First, when you close the school, especially in the spring of 2020, a lot of kids just didn't get education. And so our estimate is that the average kid lost about 54 days of education in the spring of 2020. The second thing is that especially as we get into 2021, a lot of kids transition to online learning. Online learning is in general not as effective. We're on an online seminar session here, so we don't want to say this out loud, but we will anyway. So online learning is not as effective as in-person learning, and there's some estimates from the EU in terms of the reduction in learning associated with switching to online. They had the effectiveness of online learning seemed to vary quite a bit across the EU. They had estimates for France, Germany, and Italy, and we took the midpoint estimate in terms of the reduction in learning. Once you have that, then what we do is we take the reduction in learning, and then that translates to a reduction in lifetime earning. And that's drawn from a study of an Argentinian teacher strike, where what they were able to do is they were able to show that for kids that lost 88 days of education due to the strike, they were able to actually calculate the long-term reduction in income associated with those kids. And then based on that, we can get an estimate of the lifetime reduction in income associated with education. There's an alternative formulation where they look at the years of schooling and how the effect of that on lifetime earning, and you get a fairly similar number. So we're using the more conservative number here based on the Argentinian strike, which is suggesting about $500 billion in costs, as opposed to the alternative that gets you about 750. And we're doing that consistently throughout, where we're being fairly conservative in our estimates. In terms of the costs, for vaccines, we spent a lot of time going after all the costs that we could find. So development, manufacturing, purchasing, deployment, distribution. And since this is all publicly funded, that's actually a number that's fairly easy to get your hands on. And there's all kinds of money sent to all kinds of places in society to get the vaccines out there. Hospital innovation, there were a bunch of new medications that were developed and tested. And so we had the costs of both the development and testing, and then also the therapeutic purchase in here. In terms of benefits, the benefit side, again, we calculated this in the quality world. And so we did this SIR model, and it's a 2-equation model where there's 2 pieces to it. There's the change in the number of people who are infected, and that's going to be a function of the size of the susceptible population and then the number of people who are infected. And then you're going to have the change in the susceptible population that's going to be a function of the number of people who are affected and the number of people who die. Now, in this fairly simple model, we assume that people essentially get COVID once, and then they either recover and then they're immune or they die. And that, as we've learned more about COVID, that's not quite right, because the benefits from getting COVID are going to be a little less than we thought. But to a large extent, if you get COVID or if you're vaccinated for COVID, your risk of death is dramatically lowered. And the fact that you, for example, might get COVID again, we're looking at quality adjusted life years lost. So we're just interested in deaths. And if you get COVID again, you're sick, that doesn't matter for our model. We're only interested if you survive or not. And for people who either recover or who are vaccinated, the probability of death is decreased, depending on who you want to believe in literature, by 80 to 90%. So this is a fairly reasonable approximation for how the qualities work. The key parameters in this are going to be the infection rate, so the probability of getting COVID, and then the recovery rate, so the proportion of people who have COVID who survive. And then from the structural and from the SIR model, we then move that to quality gains, where again, that we've now got fairly good data in terms of the number of average quality loss. So each death counts for 7.85 quality loss. That's from Briggs et al. In Health Economics. And then we need an assumption for what the impact of all these different intervention is. So we assume that NMIs reduce the rate of infection by 17%. That's based on a study that was in Health Affairs, I guess about 6 to 9 months ago, that looked at the effect of different interventions on it. And then there's also a very nice Japanese study where they showed that they had about a 20% decrease in infection. So we sort of see some consistent ideas that the NMIs reduce the rate of spread by about 20%. The infection fatality rate is another key input, and boy, that was a hard number to get our hands onto. And so there's various estimates in the literature that we went through, and so we're assuming that it's initially 0.5%, and then it gets reduced over time as the healthcare system becomes more effective at treating qualities. And then in terms of the vaccines, what we did is we took actual data on the number and the timing of vaccinations, and we built that into our model. We were also very interested in indirect effects, which I know has been a topic within this lecture as well. And there's a whole bunch of ways that the policies might create indirect deaths. First, obviously, is care deferral. So just people who sought out care, but the healthcare system was closed, so they weren't able to get it. We also know that there was an increase in suicides and a whole host of mental health problems associated with the lockdowns, which would also have an increase in deaths. And then finally, increases in substance abuse, domestic violence, child abuse, and neglect, which we can quantify. And then the last is increases in preventable childhood illnesses because of reductions in vaccination rates when people weren't going to get their kids their normal checkups. In terms of the numbers for this, the care deferral, I think, may be the big one. For suicides and mental health problems, and the other three, the sort of third through the fourth bullet there, or the second through the fourth bullet there, we really, it was big changes. But in the grand scheme of things, when you're sort of comparing it to potential millions of deaths, it actually ends up being relatively unimportant. So it doesn't really drive the results at all. On the other hand, the care deferral is quite important in terms of these numbers. So we know that there's something like a 50% decrease in chemotherapy treatment during the height of the pandemic. And then there was somewhere between a 70 and 90% decrease in referrals or screening. And in terms of early results, and I think we're going to get more and more as we go on, the early results suggest that you have somewhere between an 8 and a 10% increase in the death rate for cancer, 15 to 16% for colon cancer, about 5% for lung cancer, and again, about 6% for esophageal cancer. And so those 4 cancers are the ones that we focus on in terms of the indirect effects. So what we did is, we built our model, and we have 6 simulated we divided the US into 6 simulated regions, and we had the COVID pandemic hit our simulated regions at different times at different points. And you can see that the line here, the red is actual COVID-19 deaths, and the blue is what our model predicts in terms of COVID-19 deaths. And you notice that they match pretty well, and they match pretty well because they were calibrated to match pretty well. And now I want to give you a feel for kind of what's driving the results of this. So this is the blue line is our prediction in terms of the number of deaths that you would have by week during the first year if you had done nothing. So this is essentially no vaccinations, no lockdowns, predicting a 30% behavioral effect, though, even associated with the lockdowns, and then no hospital innovations. And then the red line is the number of deaths that you would have had if you had done only non-medical interventions. So you've just done the lockdowns and that kind of thing. And what you see as you look at this is the NMIs decrease the number of COVID deaths that you would have had during that first spring. So during spring of 2020. But the logic of the model is that eventually you reach herd immunity. So what that means is you're not, if you think about NMIs are reducing the rate of transmission, but ultimately you're going to get to herd immunity. So the total number of people who get sick is unchanged when you do non-medical interventions. All that you're changing is the timing of when people get sick. So you reduce the number of people who get sick during the first 6 months, and then you get more people who are sick during the second 6 months, especially that first winter would have been quite a bit higher. Let me contrast that. Now I'm adding the green ones. And the green one is if you just done hospital innovation. So we see that reduction in the probability of death per hospitalization for COVID. You can see that initially it tracks fairly well with the do nothing line. And that's because it's really it's really not changing the number of people who are getting sick, and it takes time for those hospital innovations to take effect. But then by the time you get to that first winter, you have 2 things that are different than when you just do NMIs. The first is there are more people who got sick because you had a higher transmission rate. The second thing is the number of people who are sick the people who do get sick are less likely to die. That's why you see that green line kind of dramatically below both the blue and the red line. The difference between the blue and the green line, that's that difference in the probability of death. And the difference between the red line and the green line is a combination of the timing of deaths and the probability of the deaths. And then finally, if you bring in the vaccines only, this one's a little harder to see because essentially the vaccines only line is going to mimic perfectly the do nothing line until vaccines come, which takes the first year. So essentially the first year of the pandemic would have run identically with if you've done only vaccines to if you've done nothing until the vaccines are actually there. Once the vaccines are actually there, then they essentially damp down the pandemic fairly quickly. So putting those together then, just taking the 3 simple scenarios of do nothing and then do nothing compared to NMIs, compared to hospital improvements, compared to vaccines, in our base model, you'd lose about a little over 10 million QALYs due to COVID-19. If you do non-medical interventions, you actually have higher QALY losses alone. And the reason is because you don't really prevent QALY deaths through NMI by themselves. You just change the timing of it, but you do have additional deaths because you have failed to treat people for cancer. So essentially what happens is you gain a few qualities by changing the timing of deaths. It's better to die next year than this year. I think everybody would probably feels that way. So you do have a little bit of gain when you slow down the rate of the pandemic, but it's overwhelmed by the additional cancer deaths. If you'd done hospital improvements only, you'd have about 6.4 million qualities lost. And again, vaccines would have 8.9. This is the cost per scenario. So as you look at that first line, this is the 2-year GDP loss. So for do nothing, there's a 500 billion, actually for 3 of the 4, there's a 500 billion GDP loss. So that's that 30% behavioral response, with that idea that people would have acted differently, been less likely to go to restaurants, been less likely to go to a baseball game, those kinds of things, if during the pandemic than they would have done without the pandemic. But the $1.7 trillion number for MMIs, that's that estimate from the CBO in terms of the cost of the lockdowns. The hospitalization costs end up being largely the same. Vaccines keep people out of the hospital a little bit, so you have a little bit fewer hospitalizations. But as you look at this list, obviously the 2 big numbers here are the GDP loss associated with the non-medical interventions and the educational shutdowns. So the educational shutdowns, again, using our conservative number, are something in the range of $500 billion. So when you look at the total cost of the NMIs ends up being $2.4 trillion. And the hospital improvements and the vaccines end up being more in the $500 to $600 billion range. So you sort of have a very big, you have a difference in terms of the order of magnitude. We can also sort of combine a lot of these things, because one of the things that ways you can kind of get some play from NMIs is if you do the non-medical interventions, you keep the disease from spreading through the population. That delays the number of people who get sick until, say, you have hospital innovations or you have a vaccine. Then NMIs have some benefits. So NMIs have benefits in keeping people from getting sick until other interventions are in place, which will then lead to reductions in total deaths. So that's why, again, when you put the vaccines plus the NMI, so again, if you say vaccines only, you have about 8.9 million qualities lost. If you put vaccines with NMIs, you then have only 7.5 million qualities lost. But you do have to pay the penalty of deferred care, which is, again, is a fairly big number. But you can see again here, the lowest quality loss is when you do everything, which is kind of what we did. So hospitals, NMIs, and vaccines. And in that situation, you're going to have 5.9 million qualities lost. The highest number is just doing NMIs. And so, there's a lot of numbers here, but again, we can also calculate the cost numbers. And just as you look at this table, if you look at the bottom line in terms of total cost, it's the same basic story, that if you do nothing, you have a cost in the 500 billion range. If you do anything, if you do either hospitals or vaccines or hospitals and vaccines, you're looking at a number in the, say, 600 billion-ish range. And as soon as you add in that $1.7 trillion associated with the lockdowns, now you've gone from the hundreds of billions to the trillions, and you really changed the cost of the program by an order of magnitude. This is the cost per quality gain, with the comparator being the do nothing scenario. So the do nothing, again, we don't have the cost per quality gain because that's our reference group. If you look at NMI, so that's the third column over, DOM, so dominated. So NMIs only have both higher costs and more qualities lost, so they're dominated. Hospital only ends up costing about $2,000 per quality gain. So that's a really low cost. That's the kind of cost effectiveness you see like with childhood vaccines that are well developed. I mean, that's a really low cost per quality. If you look at vaccines in isolation, you're talking about $35,000 per quality gain. That is cost effective by any standard that I know of in sort of the OECD world. As soon as you add in NMIs, though, you start to get numbers that are somewhere between the hundreds of thousands of dollars per quality gained, and then all the way to the millions of qualities gained. So the far right column is sort of what we did, and that gives you a number of something in the range of $400,000 per quality gained. If we do the comparator of hospital only, just doing the hospital innovations dominates almost everything else, with the exception of hospitals and vaccines, where if you do vaccine development on top of the hospital innovations, you get a number of about $58,000 per quality gain. And then if you add in NMIs and vaccines to plus hospitals compared to hospital only, you get a number of more like $3.4 million per quality gain, which is kind of in the range that we were seeing in the early estimates that we were doing. We did a lot of, we did tornado, we're coming up with all these parameters, so we don't really know what the distributions look like. We did tornado analyses, and the results were pretty darn robust regardless. You can do about I think we did a 50% plus or minus in terms of the NMIs versus do nothing. And you can see the cost per quality gain is going to range between 2.4 million and 1.8 million per quality gain. So just kind of regardless of what we're doing, the NMIs have a very, very high cost per quality gain. Lots of limitations here. And again, I think this is probably where, in terms of the lab, sort of thinking about where is there extra work to do? Oh boy, is there a lot. The effect of the lockdowns on the GDP is unknown. The results are somewhat sensitive to the assumption. The trick with that, sort of how strong the behavioral assumption is, that if you believe that people would have reacted strongly regardless of what the government did. So let's say, we have a 30% behavioral response. Let's say, no, it's something like an 80 or 90% behavioral response. Then in some ways, what you're saying is that the government policies were non-binding. So that means that we're overestimating the cost, but we're also overestimating the benefits. So what you're really saying is, if you pass a law that, children may not use their wings to fly to school, it doesn't really change anyone's behavior. And so if you want to assume that that the people are more sensitive to the changes, then we assume you're essentially saying that the government rules were non-binding, and then it just sort of doesn't matter. I would like to have a much better understanding of what the hospital mortality rate looked like over time. And the data that we were pulling from the CDC was not well risk adjusted. And I worry that the people who were hospitalized early may have been quite a bit sicker than the people who were hospitalized later. And so if that's right, then we're overestimating the effectiveness of the clinical innovations. Again, the number of COVID-19 deaths is not well understood. This has been a very public discussion of, did people die of COVID or with COVID? And so I think we will hopefully get a much better number in terms of what the excess mortality rate actually looks like for COVID over time. We did not include any mental health impacts. The unemployment is another big one. And this is back to this timing issue. And I think thinking about the timing of these interventions is really, really problematic because we were sort of trying to look at the scope of the whole pandemic. I'm not sure that was far enough. So, again, if you believe the work being done by NBER, you may be facing up to 1 million additional deaths associated with the recession. So as we move into a new recession, is it reasonable to say, or potentially move into a recession over the next year? Is it reasonable to sort of charge the costs of that recession and the losses in terms of health of that recession to the COVID-19 policies? Or so how long do we want to sort of say the economic effects are there? Because one thing we do know is health and wealth are very tightly linked at both the individual level and at the societal level. So these unemployment rates are going to have fairly dramatic health effects. But I'm not sure that's true of the initial one. I mean, so we're using data. We actually didn't build in any health effects from economic losses into our model. And so I'm not convinced that the effect of the COVID lockdowns would necessarily be the same as what we've seen from the Great Recession or previous work, because it was so widespread, it was so sudden, and because there were so many more resources being sent to people who lost their jobs. But I think it's an interesting question. There's lots of things, again, we didn't include. Overall, we think that all of the options that included, what we find is that all options that include non-medical interventions have very high cost per quality save. So range between 400,000 to several million per quality gain, depending on what scenario you do and what the comparator is. On the other hand, what the hospitals did was very, very, very cost effective. And in the tornado diagrams, a lot of it was actually cost reducing. Vaccines are well within the standard benchmark for cost effectiveness with, again, they're well within, depending on what you look at, which scenario you look at and the sensitivity analysis, we found a range between low of maybe $16,000 per quality gain to a high of 60,000, very, very, very cost effective. And let's see, policy implications. Timing matters. And thinking about the timing of these different interventions. So you have an intervention that reduces the spread of COVID for a month. Then what? What happens? Do those, the problem is with anything that reduces the spread of COVID, you are not preventing COVID. You're just changing the timing of COVID unless there's some other intervention that's coming down the line. And, again, so NMIs can reduce the spread, but eventually the same number of people either get immunized or get sick. Vaccines help, but only if they come in early enough to matter, and the hospital innovations save lives. The other piece of this that's not on here is that the changes in the variants and the changes in the lethality of the different variants is something that we didn't build into it. But our paper is kind of fairly deep into the review process now. But if I were to go back now, I think I would think about that question of how the different variants actually may drive some of the outcomes. Because one of the things you can do with NMIs is if there is a variant that's less lethal that comes, you could potentially delay it. Interesting ethical dilemma, I would say, of wealthy countries essentially waiting for COVID to run through poor countries to develop less lethal variants so that they can then unlock, sort of let themselves out. So the ethics there seem a little iffy. Again, I think there's a very big risk that the unintended consequences may overwhelm the COVID-19 policy gains. Because for a lot of this, what you're doing is you're trading deaths with fairly low qualities, because the deaths for COVID tend to be concentrated in older populations, for deaths with higher qualities. And again, if you look at the unemployment literature, a lot of the people who die as a result of unemployment tend to be men in their 40s and 50s. So you're essentially reducing deaths for people in their 80s in order to increasing deaths for people in their 40s and 50s. So in terms of a quality kind of trade-off, that doesn't necessarily make you stronger. I also want to do a pitch. We have a COVID CEA calculator. So it's www.covidceacalculator.site. My daughter was kind enough to help me put this together. And if you don't like my assumptions, you don't like our assumptions, you can go to this COVID CEA calculator and you can put in your own assumptions. So you can change the value of the different interventions, the timing of the different interventions, and it'll give you a cost per quality calculation for whatever assumptions you want to build in. And what I would really like people to do with the CEA calculator is, if you believe, for example, that NMIs are cost effective, what do you need to believe in order for that to be true? And then are the things that you believe actually true? Because can you actually sort of figure out if they are? Same thing, if you think vaccines were a bad idea, what does that mean in terms of the effectiveness and the breakthrough rates of vaccines and the timing of vaccines? So really, my hope is that people could sort of use the calculator to think about what they believe. I'll also say I think it's an interesting question in terms of what this implies about cost effectiveness. And I alluded to this in the beginning. Why was cost effectiveness just disregarded when these policies were done? Because we were able to look pretty early on and say, wow, the cost per quality gain really is going to be hard to justify. And so, what does that mean? Is this just an issue with the framework for qualities? I mean, we all know qualities is a local phenomenon. And, I think one valid argument might be just that we're really, the utility curve is nonlinear, and we may just be in part of the utility curve where the average numbers are not reflective of the incremental gains associated with where we are in terms of the risk of death, it could argue that the thresholds are too low, and especially the people in the United Kingdom with the National Health Service might want to think carefully if they're underspending on healthcare. Or is there some other reason why it just doesn't apply in this particular solution? And if so, why is that? So I think that's an interesting theoretical question. I'll also say, boy, is the work in this area hard. And in particular, the way we did it is we sort of put things into buckets. But if you want to look at particular policies, I think it's a really hard problem because policies are endogenous to a troubling extent in a couple of ways. First is that, we know that we tend to put policies in place as COVID cases increases. We also know COVID has this nice nonlinear property where they peak and then they go down. So if you put the policy in place and then it has an effect to reduce the number of infections that takes place 2 weeks later, and you see a decrease, is that because that's just the natural run out of the illness? Or is that because the policies were effective? And I think it's going to be very hard to tease out that difference. The second thing in terms of endogeneities, I put this picture up. So this is a paper that Dr. Van den Broek-Altenberg and I did, where we compared beliefs and reactions to COVID policies between the Netherlands and the Flanders region of Belgium, which is Dutch speaking and very similar. So there's very similar cultures with different policies. And one of the things we found is that there's so much variability in the different policies that it's really, we want to do kind of a difference in differences model to try to tease out the effect. And but the problem is there's all these different policy options, and the Oxford put together their COVID-19 government response tracker, which has all these variations in government responses. And this is just over a short time between these two countries. And you can see, who had the more stringent policies. Well, it depends on when you're talking about. So that's hard to model. And then beyond that, one of the things that we found was that the policies that were being adopted in the different countries were somewhat a reflection of the belief system of the two populations. And the Dutch and the residents of Flanders had actually fairly different beliefs in terms of the effectiveness of different interventions. And what it appeared that the governments were actually implementing policies that were more amenable to their populations. And so then when you think about trying to think about the effect of the policies, are you measuring the policy effect, or are you measuring the fact that the population thinks this is a good policy and has already changed their behavior in response to it? And so I think we just sort of have an unlimited number of studies we can do, but identifying these equations to actually estimate the policy effects of these different interventions seems to me very, very challenging. And I'm about 2 minutes past where we wanted, but I'm going to stop there and ask and see if there's any questions in the chat.
Adam, thank you so very much. There is a lot to kind of chew on with this. It's interesting to see, you're working with like dollar amounts. I mean, somebody can really kind of understand what that means, right? And it's kind of impressive because you mentioned like the timing of these things, about when you do these interventions and the kind of order in which they happen. Clearly, not doing anything is not a good thing. Depending upon the NMIs alone is maybe not a good thing. However, they may buy you the time you need to get the other interventions teed up so that you can then deploy them and use them in combination. And I'm curious about, did people fully appreciate that? Or, before you've done your analysis, was that something that people kind of understood? Or is this something which is sort of, kind of an emerging thing that you've discovered from your SIR modeling?
Well, I'll say it was not obvious to me before we started. And so we actually did start with an SIR model. We really just sort of said, well, what's going to happen over the next 2 years? And then as we tried to work through the process, we just sort of realized how important the timing of this was, which meant we had to build this entire SIR model to try to model it. So I don't think, and I think to some extent, it's still not really very well realized. Because, for example, I see people talk about doing school closures now. why? I mean,
Yeah.
and let me what, because you're not gonna keep people from getting. We've all. I mean, I know one person who's not had COVID. I mean, everybody gets COVID now,
Yeah.
and you can't really stop it. So you're just gonna change the timing of it. I'll say there's one exception that we don't have in this paper, and that's surge capacity. So if the hospitals run out of beds, you will see an increase in mortality rate. So I think that, if you look at what CDC guidelines say now, CDC guidelines, right as of, I guess, last spring or so, basically said, keep everything open unless you have a really severe outbreak in your community. And to me, the really severe means we're likely to overwhelm the healthcare system.
Yeah.
And really that policy suggestion from CDC that's completely consistent with what we're seeing as well.
And, the ethical issues that you kind of alluded to there about maybe more wealthy companies or countries rather, watching the poorer countries to see how things fare for them and then, reacting in kind. But that's, I could see that happening,
Yeah, I mean, it's pretty troubling. The other things in terms of ethical issues and that you can think about is looking at the data that's just come out in the last couple of months of what's happened with the educational numbers. I think we underestimated the educational impact in this study. And the fact that you're having the biggest effect in terms of loss of learning and also just kids disappearing from school in the lowest income quartiles of our population means I think that there's a lot of equity issues of these lockdowns that need to be thought about. And also I think that the long-term health and economic issues, this is going to make things like income inequality potentially quite a bit worse.
Oh,
and it's going to linger for decades.
I think you're absolutely right. We're going to be watching this play out for 2-3 decades. And that's the scary part to me, is that this isn't just a punctuated kind of a problem. This is going to be something which is, over a generation. And that's, incredible for our nation and for, nations around the world, and what happened to their gross domestic product, what happens to their workforce. I mean, it's going to be remarkable to watch that play out over the next, 30, 40 years.
Right. I mean, and in some ways, I would say public policy just had a lot of tunnel vision, that it was really about minimizing COVID infections and COVID deaths. And we know that things like, education matter hugely for health. And, we know that recessions are just terrible. It's like, it feels like a lot of the policies just sort of ignored decades of research.
And it's really interesting because you mentioned this when you talked about Operation Warp Speed being just remarkably deployed at, it was just so interesting how quickly it happened. And as you pointed out, within a year, we wanted to see development of these various vaccines. And it just, we saw this play out with COVID as a immediate need to do this. But I also kind of wonder, how much money have we pumped into things like cancer, where we still don't have necessarily effective vaccines for, like, breast cancer, where, what is the statistics? Like 1 in 11 women in their lifetime are going to be diagnosed with breast cancer. That's an epidemic, or what is it, like 1 in 9 or something? It's like an epidemic level of proportion. And yet we sort of just, we throw little bits of money at it, and we don't have that sense of urgency, which perhaps we should.
Yeah, and breast cancer in particular, or cancer in particular, is sort of an interesting example there, because I saw a very nice study of leukemia treatment starting in the 1950s that looked at the cost effectiveness of each of the incremental treatments for leukemia, and basically every single one failed the standard of cost effectiveness and was not, did the cost per quality gain weren't justified. But if you look at a whole over the last 70 years of work that we've done, it's extremely cost effective. And when you look at the total investments that have been made and the total gains that we're getting, it's so it's sort of an oddity that each incremental piece can be not cost effective while the whole thing can be cost effective. So
it's interesting, you talk about over 70 years. Well, somebody who has breast cancer may not have 70 years to wait, and it still may be costly for them. But nevertheless, all of these things are This is amazing, and the amount of work that you have done on this is really quite incredible. One last thing I'd like to ask you about before we have to break here is, what is the continuing role for data science and statistical modeling and forecasting that people with data science, computer science, and other sort of degrees could contribute to better understand some of these trends?
I think that there's so many numbers around in our study where I think broadly our conclusion is probably right. No, I shouldn't say probably right. I actually am quite confident that what we're finding is right. I think if anything, what we've got is we've underestimated. And I think the big question is, what are the unintended consequences of the policies? And to me, that's maybe the most fruitful area. So again, thinking about those kids that were locked out of their schools, what's the long-term effect on their employment, on their income, on their health of these kinds of lockdowns? I think that, again, when I was looking at substance abuse, domestic violence, all of those numbers, they're all up and they're fairly big numbers. But again, especially the preliminary data, we were looking at really, getting a much better feel for how much of the fentanyl epidemic is associated with COVID policies. That's a question I have no idea what the answer to is, but I would very much like to. There's a ton of work going on right now in terms of the unintended health consequences for things like cancer deaths. So again, the more we know about that, because this is a real chance to learn about the effectiveness a lot of the healthcare treatments in a way that we normally couldn't learn about it. And we would never say no breast cancer treatments for 3 months, but now we're in a situation where that kind of where we've done that. So we should learn from that.
Adam Atherly, thank you so very much for this deep dive into the just the financial burden that this recent COVID-19 pandemic has incurred upon us. And these are fascinating things, lots of richness for further analysis and diving into to further tease apart some of the nuances here of what we've just been through and how much it cost us all. I think that's very important. So thank you so much. And thank you to everybody who joined us, and everyone have a wonderful weekend. And we won't see you next week because it's Memorial Day, but we'll see you in 2 weeks hence with another in our series of the Foundations of Biomedical Data Science seminar series.